Myself, I'm Dr. Joseph K. Joseph. I'm a senior registrar in internal medicine at Taiba Hospital, Kuwait. And formerly, I was a consultant in internal medicine at VPS Lakeshore in Kochi. My pet specialties are internal medicine and diabetology. And of course, the past 2 years, we can say I'm a bit of an expert in COVID management also. Alongside with the diabetes, the biggest pandemic facing the world right now is obesity, along with diabetes. So the estimates are almost more than 25% of population in each continent is hovering around the obesity category. And diabetes, as you all know, it has crossed 470 million, and by 2035, it is projected to touch 500 million diabetes worldwide. Now, conventionally, we had the good old metformin and sulfonylureas, and of course, the regular insulins. This was in the vogue till, I believe, 2014 worldwide and also in the Indian subcontinent. Because my past experience till 2021 December was in India. That's why in between there will be some Indian anecdotes. Because Kuwait, I have been here only for 5 months, slowly gaining the pattern here also. So coming back to the focus, initially physicians and diabetologists and endocrinologists were heavily reliant on metformin and sulfonylurea and regular insulins in the past to control diabetes. But what we saw was there were patients who were having like almost they were on 100 and 150 units of insulin per day, and yet their HbA1c was about 10, fasting sugars above 160, and the ppbs was about 250, which means not well controlled diabetes in spite of taking 100 to 150 units. And even a rookie doctor knows that if you take so much insulin, you are bound to have weight gain because insulin causes weight gain, though it reduces the sugars. So we diabetologists for a long time were looking at therapies that could address both the maladies, meaning both the diabetes and the obesity. We needed a drug that could actually control sugars, but at the same time not cause weight gain, and actually, if it could actually reduce the weight, that was what we were looking for. And the breakthrough came initially in the form of the exenatide molecule that was extracted from the saliva of the Jilla monster. And that was how this whole incretin therapy started. Simultaneously, drug companies were also developing the oral DPP-4 inhibitors. Because I had a brief about the question pattern, so I saw because both molecules they act in the same pathway. The incretin therapy means it is basically, we all know the insulin helps to clear the sugar, and glucagon actually does the opposite action of insulin. So if the glucagon acts more than the insulin inside the body, there is bound to be hyperglycemia. So what a DPP-4 inhibitor and incretin does is it actually augments the action of insulin and retards the action of glucagon, thereby causing decreased appetite, reduction in the sugars, and subsequent weight loss. So that pathway is such that it is catalyzed by the DPP-4 enzyme, the incretin pathway. So what that molecules like sitagliptin, vildagliptin, these are the linagliptin, these are the DPP-4 inhibitors which we use all over the Middle East and India. It is very popular. Janumet, Trajenda, so many brands are there. Galvesmet, extremely popular because side effects are less and minimal weight gain and easy to take also. Not that expensive now. Before, when it was launched, it was expensive, but now the prices have come down. So what this inhibitor does is it blocks the DPP-4 enzyme in that pathway and augments the action of the glucagon-like peptide, thereby causing enhanced action of the insulin and the depressed action of the glucagon. Now what we have in hand simultaneously with DPP-4 inhibitors is an artificial GLP-1 agonist. First, the developed one was liraglutide called Victoza by Novo Nordisk. It is a daily injection starting at 0.6 mg, 1.2 mg, and goes up to 1.8 mg for diabetes. And 2-3 years back, FDA approved even a 3 mg dose for just obesity, meaning liraglutide can be used in a non-diabetic obese patient also. Now, the question comes is the practicality of incretins. We all know it is not very practical because it's costly. Even now, even in the Middle East and in India, it is a costly affair. Injection of liraglutide in India still costs around, for 1 month, it will cost around 10,000 rupees per month, approximately. which is not a very affordable medicine for the vast majority of populace. Even in the Middle East, like in Kuwait, it is 20, 25, 30 KD for one pen. So it is not affordable for the large populace. But why is it becoming relevant is because um, we have a huge number of patients with diabetes and obesity together. The old school of thought was first we use metformin, then we use sulfonylurea, then we use DPP-4 inhibitor. We use older insulins like Mixtard, that is the isophane insulin, or a short-acting insulin like Actrapid. This was the old school of thought, and that in that school of thought, unfortunately, most of these patients who were already obese were forced to take 100 units, and there was no control. That was when in Lakeshore, I had the privilege of managing the diabetes entirely on my own for 1 year. We didn't have an endocrinologist at that time. And those days, you all know nowadays, all hospitals, the diabetology now comes under endocrinology. So physicians getting a chance to see vast majority of diabetes cases is limited, be it my hospital or Lakeshore Hospital. But having said that, I had the privilege of managing those cases entirely on my own for 1 year at Lakeshore. And that time I started thinking, why don't we use we have attended so much seminars on GLP, so much seminars on the new kid on the block, that is SGLT2 inhibitors. That these two molecules actually revolutionized diabetes care in the past 5 years, both in India and Middle East. The SGLT2 inhibitors is a unique class of drugs that causes the secretion of glucose through the urine, thereby causing reduction in the hyperglycemia, and thereby it reduces the weight also because it has a diuretic action, and it is highly beneficial for the pumping of the heart, as established by numerous trials like the Emperor trial, Declare trial. All established the safety of the preventing heart failure and in delaying diabetes. Same set of trials were conducted with the liraglutide molecule called the LEADER trial, and the rival company, that is Eli Lilly, introduced the weekly through their landmark trials. Cardiovascular safety of GLP-1 agonists without any doubt, which means this molecule was no longer embraced by only the diabetologists and endocrinologists. Slowly, the cardiologists took up the SGLT2 inhibitors and the GLP-1 agonists in a huge way. So much so that if you check the statistics now, I think cardiologists are prescribing SGLT2 inhibitors more than the physicians and endocrinologists because of the potential cardiovascular benefits in their diabetic patients. And I was shocked in Kuwait and other Middle East, they have started using SGLT2, well predicted 2 years back by scientists, in non-diabetic patients also. In non-diabetic heart failure patients, I was shocked to see Jardians and all being written now by cardiologists. Not shocked, but it's a natural progression. So similarly, we are seeing GLP-1 agonists being now used as a standalone obesity drug, apart from being in use in obese diabetic patients. The criteria we use for GLP-1 is like this. Since it's an expensive molecule, we don't straight away prescribe it because that will put away the patient. The patient and you has to have a trust of minimum 2 to 3 months. And then slowly, if you find, nowadays, according to ADA guidelines, we use a metformin SGLT2 inhibitor combination pill as the first choice of OHA in an obese diabetic patient because it will cut down the weight. The compliance is better because it's just once daily. And SGLT2 inhibitor costs are also coming down. Initially, it was also a very expensive tablet, like 42 rupees per tablet. In Kuwait, also something like 10 KD per tablet. But it's slowly coming down the price because more and more doctors are using it. So there are some patients who, after taking SGLT2 and metformin, still we do not achieve the adequate weight loss or the good glycemic index, like HbA1c of less than 6.5 or less than 6 is our target. We see that it is still like 6.5, FBS is still 130. PPP is still at 180. Weight loss is just 2 kilos. We are not happy. We want the weight loss another 3-4 kilos. That is when we suggest to the patient, why don't we introduce either a daily liraglutide or a once weekly dulaglutide. And some patients who have their insurance covering these molecules or who are rich enough to afford these molecules, they said, yeah, fine, let's try it. So first thing we do is we warn them of the side effects. A GLP-1 agonist, as you know, it acts on the incretin receptors in the small intestine. So if you take it initially, the first few days, you are bound to have abdominal fullness, nausea, vomiting, because it suppresses the appetite basically. So the initial 7 days when you take it, you need to inject it in such a way that after taking the injection, you have to take only a small meal. You have to take antiemetic drugs. You need to take PPAs also. So you have to be wary of those gastrointestinal side effects initially. But the good news is it's transient. It lasts hardly for 6 to 7 days. That's it. Once your body is used to the molecule, then how much ever years you take the molecule, there's not going to be any GI side effects. Once you convince the patient about that small aspect, then they're as good as, they're good to go. Very often, the compliance is so good. I have patients who are still taking the molecule after even 3-4 years now. Shortest, yes, some patients, they discontinue after 3 months because of the cost. They're like, okay, I've lost my weight, my sugars are controlled, why should I take this expensive drug? So in Kerala, where I was previously practicing, it's very common. Dropouts were there. Hardly they'll take some drug. So in Kerala, where treated patients who are well informed, who don't have financial issues, most of them are comfortable using this molecule rather than daily injecting insulin. And I will tell you a live example of a patient who I had from Kuwait. She was an Indian lady working in Kuwait. At that time, I was based in India. This lady was on 100 units of regular insulin, both the conventional short-acting and the conventional intermediate-acting insulin, and the older class of OHAs like gliptins, sulfonylureas, and metformin. But when I encountered her for the first time, her fasting was 180 milligram per DL. Her PPBS was close to 300 milligram per DL. HB1C was totally uncontrolled at 11, and she was obese with 32 BMI. So you can imagine her state of affairs. And she herself was in a state of despair because in spite of injecting 100 units of insulin daily, there's no, good results to show. So she was all, depressed and dejected, and she came to me as, you can almost say like a last resort. So that was the time when I was experimenting with all those GLP and those latest degludac insulin and the SGLT2 inhibitors. That time in Cochin, only very few endocrinologists were using, and among the physicians, I was among the first people to embrace the new molecule. So let's say we were all in new waters at that time, all of us. So, but I gave her confidence. Luckily, she was rich enough to afford these changes which I suggested to her. What did I do? First thing, I reduced her insulin from 100 to 50 units of Rysodec. Rysodec is a very specialized co-formulation insulin by the company Novo Nordisk, containing in degludac and ASP in an equal co-formulation in separate entities. So the beauty of that injection is when you inject, the degludac takes care of the fasting and long-term insulin sugar control, and the ASP insulin, which is short-acting in that co-formulation, takes care of the prandial surges in glucose. So I reduced it to 25 units of Rysodec in the morning and 25 units of Rysodec in the evening. Then because she was obese, I said, let us use the SGLT2 inhibitor with the metformin rather than an APP4 inhibitor, because what you need is good weight loss. So I gave her either EMPA or DAPA, which was mixed with the metformin, and I warned her, you have to drink water properly, because SGLT2, the deadliest effects are the UTA and the genital infections. So I told her, please drink 2 liters of water daily, please clean the genital area during your bathing, and you are good to go. Then I said, one more molecule I want a once weekly GLP inside your system, because we are reducing the insulin from straight 100 to 50. So we don't know if your body will accept that. You are used to taking 100 units of insulin daily. I need something to counterbalance the reduction in insulin. So I explained to her about dulaglutide, commercially called Trulicity, and I prescribed her initially the 0.75, and I said after 1 week, if you tolerate, we will go for the full dosage, that is 1.5 mg subcutaneously. This lady followed my orders to the T. It was expensive for her, which her husband also acknowledged. But once I explained to them the benefits of what will happen to her, they were convinced. After 40 days itself, there was huge difference in her lab values. This lady lost 5 kilos in 1 month. Her fasting came down to 135. Her PPBS came down to 170. And her HB1C, will not believe, even the Eli Lilly company was shocked. From 11, it came down straight to 6.5. This is, I'm saying, in just 40 days. Patient was shocked. Patient was, how come this was not told to me by my doctors in Kuwait? I said, nothing like that. These are all newer therapies. Eventually, they will give you there in Kuwait. Because here I have more freedom to give you all these newer molecules, I gave you, that's all. Eventually, this will be the norm, be it in India or in Kuwait. Even your GP might start writing the GLP and all these molecules. There's nothing, and my prediction came true. Now everybody is writing it. There's nothing novel about it anymore. But this was in 2018 I wrote, and I was even nominated by the British Medical Journal South Asia Awards in Chennai as a Healthcare Innovation of the Year category, actually. I reached up to the semi-finals for this case. So I believe I answered both those questions. We are living in very exciting times because Novo Nordisk has introduced the world's first oral GLP-1 called Rybelsus. This is going to be a path-breaking molecule because till now people were reluctant to take GLP because it was an injectable format. As you all know, we all hate injections. So once they heard the same molecule is available in a pill format, a lot of people are now ready to embrace taking GLP-1 regardless of the side effect now. And the costs are also, I believe, 20 to 30% slightly less than the injectables. It's not cheap. It's still expensive. In India, I believe it's around 7,000 to 8,000 rupees for 1 month. But still, I tell them the benefits. Though you're investing 7,000 to 8,000 initially, you are preventing the diabetic complications which will set you apart by lakhs probably once you get admitted to the hospital. Rather than that, if you are willing to suffer the few days or weeks of that transient side effects of GI, you are actually achieving a situation where you are delaying insulin initiation by almost 5 years. So I believe this decade is the decade of incretin therapy in a big way. As more and more GPs and physicians start writing, definitely the cost will come down. Now the problem is only some niche endocrinologists and niche physicians and diabetologists are writing it, or maybe cardiologists and nephrologists also. But as more mainstream doctors start prescribing these molecules, which is the very reason why I allowed to come on this platform. My purpose is I want doctors in rural areas and poorer areas also to start writing these, because then only the cost of the molecule will come down. That is simple pharmacoeconomics. If only a certain set of doctors write a molecule, the costs are never going to come down. It will be only affordable for the rich or the insurance covered. My purpose of this video is incretin therapy. This is going to be the decade of incretin therapy, I believe, for diabetes. So if people like me who have actually used the molecule share my experiences, the other clinicians will be emboldened to use it. I don't want my knowledge to stick only within me. To enable my juniors and those who are working in rural area doctors to encourage them. There's no harm in using incretin therapies, regardless of what you hear on the Facebook or Twitter or Instagram. These are all rumors. People who have zero knowledge of these molecules are just spreading canards. No need to take that at face value. This is from a professional to a professional. I am telling you live examples, not just some theory meeting which I attended somewhere. And to sum up, another exciting thing that has happened, again by Eli Lilly companies, they have for the first time mixed a GLP-1 in a GIP-1 formulation. That is really pathway. Even for me, it is new. I was like shocked when one of my friends shared the screenshot. And they are claiming 20% weight loss. Rybelsus went up to 15% weight loss. Lira and dulaglutide had around 10 to 12% weight loss. But here you're witnessing a molecule that for the first time is claiming 20% weight loss for these patients. And FDA has approved it both for diabetes and for obesity. I believe it's called tirzepatide, the generic molecule, and Mounjaro is the brand name they've adopted. To be very honest, I am yet to use it because it's brand new. Since we were discussing incretin therapy, I felt it was my duty to share with my audience. The very latest in GLP is this GIP, that is glucose-dependent intestinal peptide with the traditional glucagon-like peptide. So for the very first time, they have mixed both the molecules in one pen. And this will also revolutionize. More and more doctors have to start embracing incretin therapies. It is here to stay. And this will break all conventional concepts we know in diabetes. It will change it forever. Insulin companies definitely wouldn't be too happy with all these advancements. But doesn't mean insulin will go out of the wall. In type 1 patients, still we have to use insulin. Even in patients on GLP, sometimes we may face failure. And eventually, if there is no beta cells producing insulin, such patients also will have to be initiated on insulin. But the best thing is probably we can reduce the units of insulin which we used previously. And that will benefit patients both in terms of cost and weight gain. And obesity will drive another big pandemic called NASH. So that is the purpose of using incretin therapy. It is not just reducing diabetes. By reversing obesity, you prevent a deadly complication known as NASH. non-alcoholic steatohepatitis. That is the third epidemic that is going to face the rich countries. Once that happens, you know very well what will happen. Some patients may progress to cirrhosis, and then the only treatment is liver transplant, which is prohibitively costly. And not success, we can say 50-50, that's all, even now. So why go for such complications if you can attack diabetes with novel therapeutics in the beginning stage itself? The proliferation of all these fast food and aerated drinks is the number one enemy, along with the salted chips. We all know, we all love going to multiplex. Even I like going to the malls and multiplex. So this M&M syndrome in the metros of India and in Middle East, it's already established. Be it Kuwait, Dubai, Jeddah. I grew up in Saudi, Oman, Bahrain, Doha. Now the World Cup is coming to Doha. Everywhere M&M, that is multiplex malls culture. So people are better than eating their home food. They're comfortable with having, let's say, a KFC or a McDonald's because it's easy to eat, quick to get. And with that, they just wash it down with a big jug of Pepsi or 7. They don't realize each glass of Pepsi or 7-Up contains around 8 spoons of sugar. And now the summer has started in the Middle East. Hardly there's any physical exercise. Obviously, your waistline starts getting bigger. So this acts as a vicious circle, actually. In India, also the same thing happens. Children prefer eating all these processed noodles, junk food, burgers, pizzas, parties. So what they don't realize is the trans fat and the sugars that they consume daily causes obesity, and that obesity drives insulin resistance, and they develop diabetes at an earlier age than they should have got. If, for example, if they were genetically programmed to get diabetes by 46 or 47, we are now seeing patients, 28-year-old IT professional walking into our clinic with high sugars. We are seeing children, teenage children with obesity of 32 waistline, and they are struggling to keep the FBS below, let's say, normally in children, when I was in school, 90 to 100 was the normal fasting. Now we are seeing children with 120 to 130 as the normal fasting yardstick. So this is the way the danger is progressing. So for that, government should tax these sugar products more. They should discourage children from consuming soft drinks. They should encourage children to eat more of healthier food and restrict taking all these junk food to only once a week. And once this message is conveyed to the children in a good way through schools and educational institutions, the same message should be conveyed to adults, especially working professionals who have a tight schedule. Like your case, my case, IT professionals, chartered accountants, especially those professionals who are paid very high, finance professionals. We are under extreme stress most of the times. We don't have time to eat food properly. We end up ordering all these online food things. Even myself, I'm guilty of doing it. I don't mind admitting it. So what happens is later on, you are sitting duck for developing obesity-induced NASH, which may become fibrotic, and finally cirrhosis. I'm not saying all patients will become cirrhotic, but you may be among the 1 or 2% patients who may be unlucky to develop cirrhosis later on. So if you have obesity, please exercise 30 minutes daily by brisk walking. Please avoid aerated beverages always. Once a week is okay. Please do not, indulge yourself with ice cream and chocolates on a daily basis. And the best thing I can give is eat more of healthy food, like natural food, fibers, proteins. Even if you're drinking Pepsi, try for a diet Pepsi. And apart from exercise, and you need 8 hours of adequate sleep. All studies have proven that less sleep means more weight gain. So that means sleep, uninterrupted 7 to 8 hours of sleep is a must if you want to counter obesity. And you have to drink 2 liters of water daily. Most of the celebrities, they drink 2 to 3 liters of water. Most of us, we go awestruck seeing their toned bodies and all. It's all because of their healthy diet, actually. Of course, they burn their calories, but they are very careful about what they put into their mouth also. So if you do all these small tips and measures, I'm not claiming we will all look like Bollywood actors or actresses, but at least it will be healthy for us, which is the whole purpose of this discussion. Though the glutens are there, though the GLP is there, newer insulins, including once a week insulin, but still will delve on the first molecule, that is biguanide class of drug, that is the second class of drugs that was developed, and then DPP-4 inhibitors. So though it may be like a relic molecule later on when my young students get into clinical practice, they will know about the theory part of DPP-4. And unfortunately, world still there is a huge economic imbalance. In India, there are still many patients who don't even have access to metformin, or let us forget about GLP and SGLT2. They don't even have access to metformin and sulfonylurea, that too, even generic molecules. So in tribal areas and rural areas, and even in the deserts of Middle East, patients, some of them may not be covered by any insurance coverage or government patronage. The DPP-4 inhibitors may still be relevant. In such class of patients, even the newer generation of doctors who pass out, they will remember that in economically challenged areas like African continent and all, DPP-4 inhibitors will continue to be relevant. In fact, in India, now the highest prescribed OHAs is the DPP-4 because so many brands are there. 100 brands of vildagliptin, lots of brands of sitagliptin, even linagliptin, very soon it will lose its proprietary status. So you can expect dozens of brands of linagliptin. And linagliptin also around 100 brands are there in India. So right now the most widely prescribed OHA in India is still DPP-4 inhibitors. But as more doctors embrace the technology of SGLT2 and GLP-1, then I believe slowly the market proportion of DPP-4 and metformin will slowly come down. It will happen in the next 5 years. But till then, DPP-4 inhibitors shall continue to be relevant because it's more accessible, more affordable. Only thing, when you use GLP-1 and DPP-4, it's better to remove the DPP-4 because both the actions are similar. This is what senior physicians say. I wouldn't say it is entirely wrong to combine both because it acts synergistically. But in theory practice, if you look, since the GLP-1 acts exactly in the same way as compared to a DPP-4, when you combine the other molecules, it's better to remove DPP-4. We all learn from our teachers, so that is what our seniors have told us. But it will remain relevant for another 5 years, definitely. My advice to my young colleagues is please keep. One way I became relevant in the state of Kerala, as you know, is a very competitive state. Huge number of doctors there. Everybody is jostling for space. The only way I kept myself relevant there was I was updating my knowledge on a regular basis. Whatever CMEs I attended or whatever new I came across, I started using it on my patients. That's the only way you can go forward in diabetology. It's not enough you just attend conferences and CMEs or publish something. Use it on the patient, convince the patient, get some works published or participate in a company-sponsored trial. There's nothing unethical about it because you're declaring everything to the National Medical Commission. So be an innovator and don't be just a follower in diabetes. That will benefit both you and the patients. That is my take-home message.